Yeah. You've done echo before, yeah?
No, I haven't. And I wondered also, will folks be able to see any of the slides, or how does that work? Okay.
Yeah, so we have it uploaded here, and John will, and so your video will go away, and it'll just be the slides.
Got it. Okay, perfect.
And then at the end, we'll just kind of open it up to you know, basically about a half-hour talk, and then open up, and they may ask questions about this topic, or they may ask any geriatric questions.
Okay, sounds great.
Kind of like the curbside thing.
Happy to do that.
People are shy, but sometimes they have good cases, so it's a little hard to, it's a, you know, see what the day brings kind of thing. Okay, so it is 12 o'clock noon then, so I think we're going to open it up. Are you ready, John?
Okay.
Make sure you record.
Yeah. Okay, tell me when I should go. Yeah?
Great.
Okay. John, am I open? Or not yet? Am I on?
Yes.
Oh, hi everybody. Welcome. This is Dr. Aida Nguyen. I'm a geriatrician with the Department of Geriatric Medicine at the John A. Burns School of Medicine. We are so glad that you have joined us at our monthly Geriatrics Echo. If you've never joined us before, we run the series on the second Wednesday of each month from 12 to 1 as a 1-hour session. After a short lecture from an expert, we will share expertise from the rest of the team and then open up for a time for case discussions. We invite you to share any geriatric cases, even if they not be on the topic at hand. Our interdisciplinary team is willing to teach and share our collective wisdom with you, and I'm sure you have experiences and wisdom to share yourself. We only ask that you keep it HIPAA compliant for case discussion. And for those who present a full case, they have the opportunity to receive a $150 gift card courtesy of ECHO at the UH AHEC. The CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between Hawaii Medical Association and JABSOM at University of Hawaii. This program is also approved for the National Association of Social Workers, the Hawaii chapter, for up to 1 social work continuing education contact hour. And as a reminder, you must complete the evaluation form in order to receive CMEs, CEs, or certificates of attendance. And the evaluations can be found on our website under the Evaluations tab, or by following the link in the chat box. We also ask you to enter your full name and credentials into the chat box so that we can keep attendance. So as you know, all sponsors of CME are required to execute a conflict of interest policy, and speakers are expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Dr. Walter, who is our guest speaker, has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So today's topic is cancer screening in older adults. I am pleased to introduce our speaker today, who is Dr. Louise Walter. She is a professor of medicine and chief at the UCSF Division of Geriatrics. So she's calling in from San Francisco, and we're just so pleased that she is willing to do this. She is a clinician researcher who is a national leader in evaluating the real-world risks and benefits of cancer screening in older adults. She received her medical degree from Stanford University in 1995 and completed a residency in internal medicine and fellowship at geriatrics at UCSF. She joined the UCSF faculty in July of 2001 and is a geriatrician at the San Francisco VA Medical Center. She is Associate Director of the UCSF Clinical and Translational Science Institute Career Development Program, and Director of the San Francisco VA Geriatric Health Services Research and Development Program to improve care for veterans with complex comorbid conditions. She is also the core leader of the Research Career Development Core at the UCSF Pepper Center for Aging Research. We look forward to hearing her teach us today. I also want to introduce the rest of our interdisciplinary team. We have Mary Gotham with the Department of Health, Public Health Nursing, and we have Chad Kawakami, who is Associate Professor of Pharmacy at the School of Pharmacy Practice in Hilo. And finally, just a few echo logistics. We want to stay HIPAA compliant, so do not share protected health information, and we can discuss cases without identifying information. There is a mute button at the bottom left-hand corner. Make sure that it is on mute, otherwise we will hear lots of extraneous noise and paper rustling. Unmute yourself if you want to speak up. And there is a chat button, and if you press it, it will bring up a chat box. And if you haven't already, please type your name and the names of all those in the room listening with you as our way of taking attendance. Okay, so without further ado, I'd like to have Louise start. Thank you.
Terrific. Thank you for the introduction. I'm delighted to be participating. So I'm going to be talking about cancer screening in older adults, and specifically, really, how do you make individualized decisions? Thinking about risks and benefits and weighing that according to an individual's health, life expectancy, and values and preferences. And do I control the slides or someone else does?
Just let us know and we will move forward, slides forward.
Okay. And I have no relationship, we talk no financial relationships. Next slide. So I think the objectives that I want everybody to take away today is to be able to think about life expectancy when you're making cancer screening recommendations. We'll talk about how to do that. We'll go over what are the current guidelines and areas of controversy and how do you kind of meld those two things together in terms of what, when you have differing guideline recommendations. And we'll talk about the cancers that have the best data or the best evidence of benefit for screening. And then we'll talk about how to develop an individualized approach to cancer screening in older adults, and we'll go through a couple cases. Next slide. So let's start out with our first case. This is Mrs. A, or Ms. A. She's a 75-year-old woman, has congestive heart failure, COPD, dependence on others for shopping, difficulty walking a quarter mile, comes in for a clinic visit, and asked about cancer screening. You know, she's like, I haven't had any for a while. Should I have a mammogram? Should I have a pap smear? Should I get screened for lung cancer? Yeah, what kind of cancer screening test should I have? So for folks on the call, just have you start thinking about what would you recommend for Ms. A in terms of cancer screening? Next slide. And then Ms. B, same age as Ms. A, but all she has is hypertension, and she walks 2 miles a day, plays tennis, comes in for a clinic visit, and has the same question about what kind of cancer screening test should I have. And so think about what you would recommend for Ms. B, and would those tests be different? Would you recommend the same kind of screening tests for Ms. A and Mrs. B, or would you have differing ones? And how would you make that decision? And we'll come back to these two cases at towards the end after we go through sort of a way to think about it. So next slide. So hopefully, one of the things I'll be talking about today is why life expectancy is important for cancer screening. And it's because right when you get a screening test, someone doesn't instantly benefit, because remember, screening's about you're doing a test in someone who has no symptoms. So they feel fine. This is not about, you know, workup for a breast lump or for GI bleeding. This is someone who feels absolutely fine, and you're trying to think about whether to screen them for an asymptomatic cancer. So of course, when you're screening them, they don't benefit right away, that they benefit by finding an asymptomatic cancer at this early stage that over many years would cause symptoms or ultimately could potentially kill them years later. And so there's this idea that there's a lag time to benefit for cancer screening or for many preventive interventions, which is the time between when you do the test and when you see improved health outcomes. So in geriatrics, we always ask, you know, when will it help is just as important as how much will it help. So, you know, a big trial might show that, you know, this an intervention, you know, provides a decreased mortality, you know, improves mortality. But if it happens after 10 years, you know, it's not going to help someone who only has a 2-year life expectancy, for example. Next slide. So the lag time to benefit for cancer screening, in general, the rule of thumb is it's about 10 years. This is true for breast cancer screening, colon cancer screening, lung cancer screening. It's probably longer for prostate screening, prostate cancer screening, more in the realm of 15 years. And then the one sort of differing cancer is cervical cancer, the way we think about it, because we know what causes cervical cancer. It's the human papillomavirus, HPV. And so if someone's had regular screenings, either with cytology, a pap smear, or by the HPV test, and they've had normal tests during their reproductive years, the chance of that woman developing cervical cancer after 65 is remote. And so people can stop, oops, sorry, I put my phone on. People can stop screening regardless of life expectancy if they've had a normal screening history. So history is more important in cervical cancer, whereas we think about life expectancy for the other cancer screening tests. And I will say, you know, when we talk about lag time to benefit, there is a question even about benefit of screening in older people, just like benefit of many things we do in medicine to older people, because older people are oftentimes not in the big trials that have shown the benefit. So there is, as with many medications and other interventions, there is uncertainty about the benefit in people over 75, not because trials have shown that it doesn't work in those folks, but just because trials did not include people over 75. So we're extrapolating that the benefit shown in younger people still applies to older people. And I think there's a lot of indirect evidence that suggests that, you know, a cancer screening test doesn't stop working when someone goes from 75 to 76 or 76 to 77. So, you know, many of the tests actually become actually more accurate, like mammography. So, but anyway, I'll put it out there that there is uncertainty, and this is where the benefit is uncertain. Next slide. So the framework for how you think, for thinking about cancer screening is you would like to target cancer screening to folks whose life expectancy is greater than the lag time to benefit of that screening test. So people whose life expectancy is less than the lag time to benefit of that screening test, you know, they're unlikely to survive to benefit, but they're exposed to the harms, which happen right away. There's really no lag time to harm. As soon as you get a colonoscopy, you can have a perforation. As soon as you, you know, get a biopsy, you can get an infection. So folks with a limited life expectancy are subjected to all the harms, and oftentimes their diseases or their frailties make them more likely to have a harm, but they don't have the chance to benefit. So let's go to the next slide. All right, so the other thing to think about is that all cancer screening tests can cause harm. And I think about harms in sort of three areas. So one is the complication from additional procedures to work up inaccurate test results. We've all heard of false positive results. You know, when a screening test comes back positive, but then when you get further workup, you find out the screening test was wrong. I think the biggest harm I see in my older and sick patients is the identification and treatment of clinically unimportant disease that would not have progressed to symptoms in a patient's lifetime, but because we got a screening test, we found an abnormality, we got a bunch of workup, we actually treated it, and they were harmed. And we'll talk about that. And then there can be the psychological distress from those types of harms. Next slide. So I thought one of the ways to show or demonstrate some of the harms of cancer screening is to talk about a study I did at OnLock, which is this really wonderful program, part of the program of All-Inclusive Care of the Elderly, or PACE. Which is a health program that cares for frail older adults who otherwise would need a nursing home, but because of this program, they get extra services so that they can stay at home. It was interesting when I first got interested in this area in the late 1990s. PACE was a fairly new program, and so they were being audited a lot. And so the state auditors came up, and one of the things they pointed to in terms of a measure of quality was the screening mammography rate. And they said, oh, your screening mammography rate at OnLock is too low. And that means you're providing poor quality of care. And we're going to ding you if you don't increase your screening mammography rate. And so they insisted that mammograms be performed on all women who enrolled in the OnLock program. And they didn't care how sick they were because they pointed to the American Cancer Society guidelines, which at the time said you would screen someone no matter what. So they didn't care that 50% of the patients, you know, entering this program had, you know, severe dementia, or that we knew that the median life expectancy was 4 years for the program. So as I was sending, you know, the 98-year-old woman with severe dementia for a mammogram, for a screening mammogram, we decided, let's assess the harms and really understand, is this program doing good, or is it doing bad things? Next slide. So this is sort of shows you the flow diagram of what happened, and that we actually found that screening mammography in frail older women frequently led to harm. So this study is basically, we looked at 216 women who had a screening mammogram on enrollment into the program between 95 and 97. And right off the bat, we found, you know, there was a high abnormality rate. 38 had an abnormal result. And a lot of this was because people who had severe dementia did not hold still in the mammogram machine, right? Or hold the right position. So there was a lot of motion artifact and call back to have additional tests because they didn't get a good result. Next, click the next thing. And of the folks that had an abnormal result, 6 refused further workup. We counted those folks as being harmed because even though they were too sick, like a lot of the folks were like, especially the family was like, my mom has had enough. But we counted them as being harmed because they still worried about, did they have breast cancer? The family is like, does this mean, we have breast cancer in our family history? And it set up a lot of anxiety for something that was not going to be worked up. So don't send a test if you're not planning to work it up. Of the 32 who agreed to work up, hit the next slide. Next thing, 28 had a false positive result. So a lot of these folks had additional biopsies, additional imaging, ultrasounds to be, again, told that the mammogram was wrong, that they did not have breast cancer. And then you'll see that 4 the women were diagnosed with early stage cancer or something called ductal carcinoma in situ, which is this sort of pre-cancer or cancer risk factor. And if you stopped it there, you might say, oh, this program is detecting a lot of these hidden cancers and is doing good. But we decided, well, what happened to these 4 women who had this diagnosis? So click the next thing. And what we found is that they all were treated surgically, but they all died of other causes within 4 years, suggesting that actually finding these asymptomatic lesions and doing a lot of treatment to them actually was harmful. And the next slide, if you go to that next slide, really illustrates this fact. This was the woman who was diagnosed with the ductal carcinoma in situ. She was a 80-year-old woman with severe dementia for multiple strokes who underwent screening mammogram on enrollment because of this program and had an abnormal mammogram. I remember she had some calcifications. She underwent 2 fine needle biopsy attempts trying to figure out what it was, and both came back inconclusive results. And the family was so worried that this could represent cancer that they said, well, you know what, let's just have her get it excised, and took her to surgery. And she had, she was diagnosed with ductal carcinoma in situ, which again, and maybe over 20 years, 25% of those lesions will become invasive cancer, but most of them do not. And it's over a long time. But then she had all these horrible things happen to her because she was so frail. She developed a wound infection requiring daily trips to the wound clinic for 3 months, finally had to have a second surgery to close the wound, and then died of a large stroke 9 months later. So everybody was very traumatized and on lock about this because we would never have sent her for this test because of her frailty. But because of this program, she had been sent. Next slide. The good news is actually we were able to change the policy in that what we found out is that, just talking to state auditors about that people were unlikely to benefit was not compelling. But when you showed the state auditors of the harm that was being caused by their mandatory policy, they said, oh, that's bad. And so now screening mammography decisions at OnLock are back to being individualized decisions, which I think is appropriate because there are some people at OnLock that could benefit, but there's many others that are more likely to be harmed than benefit. So next slide. So this brings me to the really understanding the current cancer screening guidelines and areas of controversy. So next slide. So we'll start with mammography, since that's oftentimes on the news. One guideline recommends something, the other guideline recommends something else. So here's an example. U.S. Preventive Services Task Force recommends routine mammography, screening mammography every 2 years, starting at age 50. They have no recommendation for women 75 and older because that's when the data from the randomized trials is not there. The American Cancer Society says, well, actually, let's do annual mammograms starting at age 45, and we'll transition to screening mammography every 2 years at age 55 because that's when most women are postmenopausal, and every 2 years is just as good in women who are postmenopausal as every year. They recommend continuing screening women if they have a life expectancy greater than 10 years. And are very clear that if you start mammograms between 40 and 44, or you continue screening women 75 and above, that is an individualized decision that should be discussed with the woman, and that clinical breast exams should not be used in place of screening mammography because clinical breast exams are not as accurate as mammography. So I actually sit on a number of these guideline panels, and it's very humbling to look through the evidence and really try and understand what recommendations to make. Next slide. I've come to realize that scientific evidence describes the continuum of benefit versus harm. It shows the likelihood of benefit for a certain number needed to screen, likelihood of harm, but the threshold for where the benefits are actually, enough to warrant the risk of harm is oftentimes a value judgment. So, sure, there definitely are times when the benefits, way outweigh the harms, or the harms way outweigh the benefit, and it's clear-cut choice to do something or not to do something. But in many cases, the benefits versus the harms is more of a close call, or sort of uncertain or small benefit. And that's where it's really an individualized decision. And we'll talk about that, because I think that's where a lot of the cancer screening in older people falls. And we need guidelines that really distinguish between when things are clear-cut, you should absolutely promote them, and when they require an individualized decision and are highly preference sensitive. Next slide. So the old paradigm was, a test either caused great net benefit or caused a lot of net harm, and you either recommended or didn't recommend a test. The new paradigm is in between, substantial net benefit and substantial net harm, is a large area of small or uncertain benefit, which is very preference sensitive. And hit the next thing. And that means that we really have to convey that screening is a choice that a patient needs to be involved in making, and not an automatic recommendation. So, for example, if I see a healthy woman over age 75, I will say, this is when the data for the trials runs out, and I really need to talk to you about the benefits and harms of screening mammograms, and understand what's important to you and what you're concerned about. Okay, so next slide. So I put it together by, here's the guidelines for breast cancer. So benefits of screening mammograms outweigh the harms for healthy average risk women 50 to 74. I think that's clear cut and can be highly encouraged based on repeated mammogram trials showing benefit. Next, hit the next thing. The net benefit's small or uncertain for women 40 to 49 or women 75 and older, and that's when you have an individualized discussion with people about the test. Next. And it's net harm for women who have a life expectancy less than 10 years, given the lag time to benefit for mammography. Next. And then the screening interval, whether to do it every 2 years or every year, biennial screening in postmenopausal women, so generally, again, 55 and older. I think it's pretty clear cut that the benefit is the same as annual, and the harm is reduced because you have a lot less false positives since you're doing a lot less screening. Next. And the net benefit is small or uncertain, or actually I think it's small. There's some small benefit for younger women to have annual mammograms versus biennial. So that's where it's an individualized decision. And then next. And then colon cancer screening, the U.S. Preventive Services Task Force found, there's several screening strategies that show, fairly equivalent net benefit. That would be high sensitivity, fecal occult blood tests, or in San Francisco VA, we use immunochemical testing, or FIT, annually. There's sigmoidoscopy every 10 years with FIT annually, or there's the screening colonoscopy every 10 years. We tend to do either FIT or screening colonoscopies every 10 years. The other two, like CT colonography or fecal DNA, there's still insufficient evidence that the benefits outweigh the harms, just because they have a lot of false positives or a lot of overdiagnosis. Next. So for colon cancer screening, FIT, sigmoidoscopy, colonoscopy, again, I think the harms for healthy average risk older adults, or adults 50 to 75, it's clear cut. There's multiple trials showing benefit. I'd recommend it. The net benefit of screening is small or uncertain for healthy adults 76 to 85, mostly because they have shown that the risk colonoscopy, which every screening test goes through colonoscopy, increases as people get older. So it is an individualized decision for people 76 and above. And then it's net harm for adults who are 85 and older, or who have a life expectancy less than 10 years, and I would not recommend colon cancer screening. Next. HPV, this is cervical cancer screening, for women 30 to 65, either a combo of PAPS and HPV every 5 years, or PAPS every 3 years, same benefit. In fact, I'm imagining at some point we're going to be transitioning completely over to just HPV testing. Women who've received HPV vaccines should continue routine cervical cancer screening. Next. And then, so the benefits outweigh the harms of screening for cervical cancer among average risk women. I think this is clear cut. There's been multiple cohort studies showing the benefit. Next. And then there's net harm of screening women over 65 with adequate prior screening who are average risk. And adequate prior screening means at least basically having 3 negative pap smears in the 10 years before somebody stops, and or 2 negative HPV tests. And obviously women who've had a total hysterectomy who do no longer have a cervix, and they've had it removed for benign disease should not get screened. It wouldn't even be cervical cancer screening since they don't have a cervix. So those are clear cuts not to screen. Okay. And then PSA, certainly this comes up a lot at the VA. We were hoping that there would be an answer when they had these big randomized trials, but one randomized trial found that PSA screening did reduce prostate cancer mortality after about 11 years, and one randomized trial found no benefit. There's consistent data on harms. PSA oftentimes finds insignificant disease that leads to unnecessary distress, incontinence, and impotence. And again, there's no evidence to recommend other types of screening tests like digital rectal exams. So I think we're still in search of a better screening test for prostate cancer. Next. So generally for PSA screening, the trial that found some benefit screened every 2 to 4 years, did not screen annually. But because there was conflicting results, I think it's really an individualized decision. It's not clear cut that PSA is a net benefit. Next. And certainly I think everybody agrees that would be net harm for men younger than 45 or men who have a life expectancy less than 15 years. So would not recommend PSA screening in those folks. Next. Then lung cancer screening. So this is the last one we're going to talk about. Is there's, again, conflicting data on benefit. Yeah, the most recent randomized trial of low-dose computed tomography versus chest x-rays found that it did reduce lung cancer mortality in adults age 55 to 74 in this very sort of specific group of people with, 30-pack year smoking history, and the lag time was about 7 years. But other randomized trials of low-dose computed tomography have not found any benefit. There's consistent data on harms. The CT is not just limited to your lungs, so it can find all kinds of things. It can find nodules in the thyroid. And anyway, at the VA, we found that over half of our veterans had lung nodules that then they get put into lung nodule clinic and they get follow-up for that. And 30% had other things that needed to be followed up, like nodules in their thyroid, et cetera. To find 1.5% of folks that had lung cancers. So again, you're talking about around 737 false positive results that require workup per lung cancer death prevented. And so again, trying to weigh those things as well as the harms of radiation exposure. Next. So whether the benefits of annual low-dose CT screening outweigh the harms is uncertain. And I think this is where it is an individualized decision and not just an automatic referral. Next. And the net harm for adults not included in the group mentioned above, or people who have severe lung disease or life expectancy less than 10 years, it's clear cut that they should not get this lung cancer screening. So just to summarize up, putting these all together, the take home is if a person has a life expectancy less than 10 years, it's clear cut that they're not going to benefit from any of these cancer screening tests. Next. If a person has a life expectancy greater than 10 years and the screening test has consistently shown to be beneficial, like mammography, pap, colon cancer screening, clear cut if it's been within, if the person is within what's been shown to be beneficial in the studies, it's an individualized decision if the person's outside those studied groups, such as older or sicker. Next. And for screening tests that have been, the benefits inconsistent in the trials, whether that's PSA or low-dose lung CTs, I think it's an individualized decision if it's within the groups that have been studied, and I wouldn't apply it to folks outside the studied groups at this point, given the inconsistency of the data. So lastly, I guess in our last 5 or 8 minutes, let's walk through and develop an individualized approach to cancer screening in older adults. Next. So back to Ms. A, who's our 75-year-old clinic patient with congestive heart failure, COPD, dependence on others for shopping, and difficulty walking a quarter mile. So again, would we recommend that Ms. A, we'll just pick here, should she have a screening mammogram? Yes or no. So it really, right, it depends on her life expectancy. So next slide. So, if her life expectancy is greater than 10 years, then you'd have an individualized decision with her because she's older than the data in the trials. But, if she has a substantial life expectancy, she could potentially benefit. But if her life expectancy is less than 10 years, then it's clear cut that you should recommend against her having a screening test, and that the harms would outweigh the benefits. So again, what are the methods for estimating life expectancy, right? That's the real question. So next. So one way you can do it is you can look at data from US life tables. So this is data from US life tables where you have age on the x-axis and years of life expectancies on the y. And you can see the top green line that represents the top 25th percentile of life expectancy at each age. The blue line is the 50th percentile or the median, and the red line is the, would be the sickest women, the lowest 25th percentile at each age. So if you look at 80 and you just go up from that top green box suggests that 25% of women are going to live 13 years or more, who are, again, if you take all 80-year-old women in the United States, again, 25% will live 13 years or more. Interestingly, half will live 10 years or more. I think people are often surprised that 80-year-old women in the United States have 50-50 chance of making it to 90. So people live longer than we oftentimes think about. And then it's only the lowest 25th percentile of 80-year-olds who are going to live 5 years or less. So there's great variation in how long people of similar ages live. So a point is you can't just look at somebody's age to determine their life expectancy. And the graph for men looks the same. You just have to subtract about 3 years from each of those points. Next. Of course, then the question is, well, who's on the green line and who's on the red line, who's on the blue line? And so this is where I think you can bring in your clinical judgment and think about the medical conditions that a person has. Next. So it's possible to estimate if a person's likely to live substantially longer or shorter by looking at their number and severity of medical conditions. These are much stronger predictors of life expectancy than age alone. So when I'm seeing older folks in my clinic thinking about cancer screening, I always say to myself, does this person have a serious life-limiting disease? Do they have severe heart failure, that's symptomatic? Are they, horrible lung disease requiring home oxygen? Are they on dialysis for their bad kidney disease? Do they have severe dementia with many dependencies and activities of daily living? All these have very low, 10-year survival rates. So for Ms. A, if I was looking at her, she has significant heart failure, COPD, dependence in her instrumental activities of daily living. My clinical judgment would be that she'd likely on the red line, the lowest 25th percentile of life expectancy. Next. Of course, people are like, well, is there a more objective way to sort of, be able to bounce off my my clinical judgment and have a little bit more help on that? And you can think about prognostic indices to help refine your clinical judgment. Next. So at UCSF, we've been working on a website called Prognosis that basically provides easy access to validated prognostic calculators for people 65 and older. And it helps you basically, you can combine your clinical estimates with the data you get from prognostic calculators. And I use it a lot to say, gosh, I think this person looks great, and oh gosh, the calculator confirms that. Or it's even interesting when the calculator says something different, and then I'm trying to think, well, what do I know that's different from the calculator? But anyway, it just helps me feel more confident in my estimates. But if you push the red or the calculator side, it will take you to this screen where you can say where your patient is located. So this is cancer screening. This is someone who's come into clinic to see me. So we'll push the clinic, but there's also calculators for folks in nursing homes and in the hospital and for hospice prognosis. So let's click clinic, the next. And that will take you to a screen where you fill out information about your patient. So for Ms. A, we'd fill in, how old she is, what's her gender, is she a smoker, etc. So you fill all that in and you click it. So click next, and then click the next one, and it'll give you a point total, and it'll show you what, based on her score, which she got a score of 18, which is very high, that her risk of 10-year mortality is 93%. So that means given 100 people with similar answers, to this index, 93 will die and 7 will survive over the next 10 years. So very suggestive that Ms. A's life expectancy is less than 10 years, and one would recommend against screening mammography. Next. Well, what about Ms. B? So she's same age as Ms. A, but again, not only has hypertension and is very active. So again, your clinical gestalt would be that she's on that green line, the upper quartile of life expectancy. So she's likely to live at least 17 years. And e-prognosis would confirm that, showing a very low chance that she's going to die in the next 10 years. So for her, mammography screening would be an individualized decision where you think about the risk and benefits. So what you do, if you go to the ePrognosis website, there's something called it'll say cancer screening. If you click on that, you'll enter the same information you did for Ms. A, but this will show you this gauge where, do the benefits outweigh the harms of mammography screening. So you can see for Ms. B that it points more towards the green than the red. So it suggests that the benefits of screening mammography may outweigh the harms depending on her values and preferences, because again, this is an individualized decision. And then you can click on the red or the green to show you a list of harms. And sorry, it doesn't do that, but it'll show you that on the actual website, it'll list the harms and benefits. And you can have a discussion with her about what her views are. How worried is she about, the biopsy? Some people will say, I don't want a biopsy. Would never want to do that. I'd take my own chances. And other people are really concerned. Oh my gosh, anything I can do to reduce my risk of breast cancer would be great. So this is the final slide, and then I'll throw it open for discussion. I think the take home that I want everybody to think about is just to be thoughtful about cancer screening rather than just basing it on somebody's age. To not say, oh, this person's over 75, so we won't screen them, or oh, they're younger than 75, so even if they're bedbound in a nursing home and really sick, I'm going to screen them. So, but to be thoughtful and think about what makes sense. So think about life expectancy and health, benefits and harms of the tests that we talked about, and patient preferences, and having discussions with people. These are the core principles of good medicine and should be applied to screening decisions, because screening is an intervention. It's not like a flu shot, right? It has some real downsides as well as some potential upsides. So I will end my talk right there and open it up for discussion.
Thank you. All right, let's see who is on here today. Let's see, is there a
family history of breast cancer? Should mammography be done
yearly regardless of age?
Yeah, so the question about family history and how does that change. So as you notice, I put these are average risk women, so family history, even in older women, does increase the chance that one will be diagnosed with breast cancer. So that might make you say, gosh, I want to screen either annually or screen longer. We're actually in the midst at the American Cancer Society of coming up with guidelines for high-risk women and what defines high risk, because there's many risk factors, right? And how do you decide at what point the person meets that threshold for being high risk? So it's a complicated question in terms of, but usually, but it does increase your risk. So it would not be unreasonable to do it every year for someone who has a family history, even as they get older. Yep.
Great. Any other questions?
Do people struggle at all with any of these? I actually got into this because I struggled. And in fact, I get a lot of quality metrics that say I should be doing something to people that are very ill. And I'm thinking, oh, if I send this person for a screening colonoscopy, I'll likely kill him because he's got all these other heart failure and, anyway. So I don't know if that's something, but I find that with the quality metrics, it oftentimes goes against that idea of making an individualized decision.
Yeah, which drives us to the next question. What if prognosis is poor, but the patient insists, right? It's part of that individualized thing.
How do you individualize? So I always put this as part of the art of medicine. And I put it in the same category as what do you do when a person has a cold and they want antibiotics, right? I think in many cases for cancer screening, people don't realize there's any downside. We have all these public health campaigns saying, do it, save your life. And so it's hard to kind of flip to say, oh, that there's a time when someone gets very ill and has other things going on that cancer screening is more harmful than beneficial. So just like I do with when someone comes in with a cold who wants antibiotics and have a discussion about the harms, I'm like, I could give you antibiotics, but also it could cause you to have, severe life-limiting diarrhea. It could make it so that when you really need it, the bugs are going to be resistant. And many people, once you explain the harms, say, you know what, I had no idea. I do not want antibiotics. And the same thing with cancer screening. If you talk about, well, the next step if I get this mammogram is a biopsy, you know, given how sick you are, you're at much higher risk for getting an infection, you know, here's all the downstream things that could happen. And many people like, I had no idea. And then they oftentimes will say, yeah, I agree. That doesn't make any sense. I didn't realize that there were harms. Of course, there are always people like, you know, that want to have the antibiotics for a cold, or they want to get a screening test when you think it's more harmful than beneficial. And I think that's, again, where you have to say, what's my line, right? So, you know, in terms of when do you cross the line that I feel uncomfortable doing that? So, you know, certainly when people come to me and say, I absolutely want, you know, a PSA test, prostate, you know, and I explain the harms and benefits, and I might think that that's not the best thing for them. But if they really understand the harms and benefits, I will send that. You know, I feel like, you know, they are informed, and I will send that. On the other hand, I can have people say, I absolutely really want barbiturates. And my line is like, nope, you know, I'm going to just, you know, I can't do that. That's going to, you know, even if it's going to disrupt the physician, you know, patient bond, that's a line I won't cross. So I think you have to come up with your, you know, what makes you feel comfortable. But I generally feel if people are informed about screening, that, you know, I do want to preserve the physician-patient bond. Yeah, unless I think it's going to be really, really harmful. So.
Yeah. So it sounds like, you know, there's been really great public health campaigns about cancer screening, and that sort of needs to be undone a little bit whenever they get. So I'm just thinking, you know, have you done like these educations in assisted living facilities and things like that? Because that's kind of the population where they all ask.
Yes. You know, we have increasingly done that. And it is interesting because, again, this is like oftentimes the first time people have heard that it might be harmful. So people have a lot of questions around that. Yeah, in general, and it really depends on the screening test too, which also speaks to the public health campaign. I have yet to have a woman, you know, be very upset about stopping cervical cancer screening. I don't know. She's, you know, you know, versus mammography, you know, people have been very wedded to this, and this is something, anyway, it's just interesting. And again, different people have just different responses. So it's so important to understand, you know, what's important to people. How do people approach medical care in general? You know, I have people that absolutely, you know, try to have minimal, they don't want a whole lot of stuff done to them. They don't want aggressive stuff. And you have other people that believe very strongly in that medicine is going to save them. And yeah, I think it's more starting the conversation, having conversations, so at least people have some understanding of potential downsides, and making sure that you'd actually do something with the result, right? I think the worst thing is when you get a result and it's positive and then you don't do anything with it, because that then sets you up for a lot of questions.
Yeah. There's a comment that says, thank you for a very good presentation. Using the core principles, listening to the patient, and individualized decisions are so important.
Mm-hmm. Yeah. Yes. Well, I think that is geriatrics, right? I mean, that is sort of a lot of stuff, because older people have not been in trials. A lot of stuff we do has smaller uncertain benefit, and it really does depend on what people value, what's important to them. Are we aligning what we're doing in medicine to them, to what matters to them, right? I mean, that's part of the whole 4 M's, you know, of understanding what's important to people. I think cancer screening should fall in that. Yeah.
That comment just, I mean, she's a social worker, and I know that we have public health here that really, it's a lot of our partners we really rely on to kind of help share this information and corroborate with us.
Yeah.
You know, so we're all like really talking about the same message. Do you have any comments from public health perspective?
I'm just thinking about a lot of times we've seen people who are frail elders that are living alone and have some dementia and everything, and yet they had like a colonoscopy ordered, and we're like, how do you think this person is going to do the prep by themselves? And
right, and that's going to be harmful, right? They're going to take it, they're going to get dehydrated, they're going to fall, right, all by themselves.
Yeah, or just forget to do it, and then they won't, you know, so it's just kind of surprising it's still being ordered for somebody like that.
Yep. And sometimes I hear that people are afraid of like legal, you know, I think, again, and this is not, unique to cancer screening, that in medicine in general, people always feel like I have to do something. It's easier to just do something. Easier to put the feeding tube in the person with severe dementia, or easier just to, than having a discussion, which takes real time, is not reimbursed, right? And then people worry, oh my gosh, could I be in legal trouble? Whereas, well, if I order this, even if it's, not going to help the person or potentially harm them, at least I said I was doing something. So I want to point out that, the guidelines now are pretty clear that it is not standard of care to, recommend any screening tests for people that you just described, who are frail and have dementia and are living at home. So, if you document, I think it's about documentation in your chart that this person has, has dementia, has this stuff, and the harms outweigh the benefits, that would be fine. Yeah. So.
I was just thinking, sometimes I find it's helpful to kind of just sort of paint the scenario out for them. So this is what it's going to look like,
right,
if you do this. Mm-hmm. And these are the things specifically that you may encounter. Otherwise, it's kind of a little bit too abstract. So
I agree. And in fact, any cancer screening test that I talk about, I always talk about, this is the screening test. And if it comes back positive, it comes back abnormal, this is the test. So that people don't think, oh, if I just get the fecal occult blood test, I'm done, right? That's easy. But no, actually, if it comes back positive, I want to know, would you agree to colonoscopy? Because having a positive FIT test tells me nothing, right? It just means because most people who have a positive FIT do not have colon cancer. But you have to get that colonoscopy to know if you have colon cancer. And so if people are not willing to do, like, the screening test is really it's really the screening plus the diagnostic procedure is what is meaningful, not just the screening test. So people have to be okay with doing both of those and understanding that. And then people even will take it a step further, as you have to be able to tolerate, the treatment of what is found. So.
Okay, any other questions from the participants? And if you have any geriatric questions, cases not related, we're happy to talk about that as well, since we have geriatricians here.
I would just think that because people are living even longer and are even healthier longer, that there would be some people that would be, maybe even 80, where it would still be reasonable to do the screening, because they're still so, functioning very well and having a good life.
Yeah, in fact, this reminds me, because Dr. Lewin's on the line here too, and I saw him the last time, and we had a discussion about ageism, and that many times I think the physician, as you as a physician, can actually be advocates for them, because there's folks who write you off and say, no, not for you because you're too old. But actually, if you're fit and you're healthy and you've got actually a good quality of life, no, that's not the way we go.
Because nowadays we even have like people in their 80s who are still, working and having very full lives and are in very good health.
Yep. No, I would say I wear two hats. I wear one hat for my very healthy elderly people that are told you can't get something. Like, to try and get a mammogram for women over 80 in the VA, it's like, oh my goodness. Or even trying to get any type of other types of screening tests, you have to really advocate that, no, just because they turned 80, they're super healthy. They're hiking in the mountains, they're physiologically young.
They're likely to live over to 100. In fact, we have so many people in Hawaii who do that, because we have actually one of the longest lived populations.
So it's really important to advocate that people don't get written off because of their age, right? The whole idea for this of my talk is not to base your decision on age. And then my other hat is protector of all my folks that are so ill and so frail. And because they are so ill and frail, they see a lot of the health professions and are much more risk for getting crazy things done for them, right? It's interesting that in medicine, like, the people you want to get the prevention stuff being done to are the healthy folks that rarely see healthcare folks. But those are the folks that are going to benefit. And it's the folks that are so frail and so ill that end up getting a lot of these tests just because I think that they have exposure to the health system a lot more. And at some point, someone orders some of these crazy things. So I wear both hats in terms of a protector for folks that are frail and very ill. And the idea is to really focus on what's causing them to be so frail and ill. Because I guess another harm I didn't mention is what we call opportunity cost, in that the more you focus on something that has a low chance of benefit, or even more harm than benefit, the more you're taking time away from something that could be beneficial. Like, we could be treating your heart failure. We could be helping your caregiver. All the things that would make your, live longer and better. But because we weren't thoughtful, we're sending you on for all these screening tests that are not going to help you, but take time away from things that could be. So I think that's the other harm to try and avoid in our frail folks is, there's only so much time in the day. So time doing one thing is time not doing something else.
And a missed opportunity to talk about what matters.
Absolutely. To have that discussion, to have discussions which helps you across all the medical things, not just screening, but what their approach to medical care, what makes life worth living. Like that's how I start. I really try and, understand what it is that makes life worth living and what's important to people, because that helps, when they get really sick, what kind of things are going to be helpful.
Yeah. Great. Yeah, so the comment, we have several 100+ in our life care community. People are definitely living longer, some with good quality of life. Yes.
Yep.
Any other questions, thoughts, comments, cases?
Let me get off pretty easy here.
Yeah. Guys. Got to make it challenging. We like challenges.
Absolutely. That's why we go into geriatrics, for the complexity and for the,
Great. And if there's any other topics that you guys also want, you can also type it in the chat box too, because we need to, plan ahead and fill in slots in the future. We would love to talk about what interests you.
Yep. And I think the other thing, the point I'll make is sort of this framework for thinking about risks and benefits in the context of somebody's life expectancy and health and patient preferences applies to other things, other types of preventive things. Like, we've been using this framework now around diabetes, right? In that, you don't need tight sugar control, again, in someone who has a limited life expectancy. In fact, that's more harmful than beneficial. And so anyway, one of the things we're trying to do is think more, we have more information about lag time to benefit for a lot of things that we do preventive wise, because that would help decide when are you going to stop your statin, or when, so because we get a lot of people sent to hospice who are still on their cholesterol medicines, and we're like, that doesn't make any sense. So so the same kind of thing is thinking about what is the chance of benefit for, according to the life expectancy, and when is it making more harm than benefit, and then what's important to people.
Great. All right, last chance for questions. All right. If not, tune in next month. Our next meeting is February 12th, and our topic will be working with adult protective services to keep our kupunas safe. So lots of great challenging cases I'm sure you guys have out there that you want to talk directly to somebody from APS. So please come back next month. Thank you. And don't forget to fill in your evaluation forms and get all your CME credits and CEs. Thank you.
Thanks so much. Really appreciate being part of this.
Okay.